All right, buckle up, because today we're peeling back the layers on something truly amazing happening inside you right now. Have you ever truly stopped to think about the incredible ballet your body performs just to keep your blood sugar perfectly balanced?
It really is something.
It's not just an intricate dance, it's a masterpiece of biological regulation, and in this deep dive, we're uncovering the unsung hero orchestrating it all, the endocrine pancreas.
What's truly fascinating here is how a relatively small organ, often overshadowed by its more commonly known digestive role, plays such a monumental and intricate part in our overall health and metabolic stability.
Right.
Today, we're going to explore its hidden depths, taking you from its very first appearance and delicate differentiation in an embryo, all the way to the complex diseases that can arise when its critical balance is disrupted. From widespread conditions like diabetes to incredibly rare yet impactful neuroendocrine tumors.
Our mission today is ambitious. We want to give you a shortcut to understanding the endocrine pancreas like an elite professional. We're talking about mastering this information, truly grasping the why behind the what. We've got a stack of incredibly rich sources, primarily a comprehensive medical textbook to guide us.
Yeah, really solid stuff.
You're going to hear about groundbreaking discoveries that fundamentally change the course of medicine. You'll visualize the microscopic marvels that make it all work at a cellular level. And we'll explore cutting-edge treatments for conditions you might never have even imagined. So as we embark on this journey into one of your body's most vital and often overlooked regulators, what stands out to you?
I think just the sheer complexity packed into such a small space, the way it juggles digestion and hormones, it's remarkable.
Okay, to truly appreciate the endocrine pancreas, we first need to set the stage, put it into context. While its full function wasn't understood then, the pancreas was actually identified over 400 years ago by Greek anatomists. Wild, right?
Yeah, amazing how long ago that was.
Today, we know it's nestled deep within your abdomen, tucked away behind your stomach, specifically in what's called the retroperitoneum. Its head is perfectly cupped within the C-shaped loop of the duodenum, which is the very first part of your small intestine.
And that precise location isn't accidental. It's quite strategic. The pancreas is truly a gland with a dual identity, a master of multitasking. It performs distinct hormonal or endocrine functions, and that's our primary focus today.
Got it, endocrine.
In this role, it secretes hormones like insulin directly into the bloodstream to regulate processes throughout your entire body. But it also has crucial digestive or exocrine functions where it produces powerful enzymes that flow into your intestine to aid in breaking down food.
So hormones and digestion.
Exactly. It's this remarkable dual role that makes it so indispensable to your daily life.
And it's within that dual identity that we find a landmark discovery that fundamentally changed our understanding of metabolism. Back in 1869, a keen-eyed medical student named Paul Langerhans, a student.
Yeah, just a student. Incredible.
He made an incredible observation. While studying pancreatic tissue under a microscope, he found these discrete, tiny clusters of cells scattered throughout the pancreas that looked different from the surrounding digestive tissue. He named them, quite simply, the islets of Langerhans.
Right.
The real aha moment, which came later, was realizing that these particular cell clusters weren't involved in digestion at all. Instead, they were the ones responsible for secreting hormones directly into the bloodstream.
That's right. Langerhans's initial observation, even without knowing the full why, laid the absolute groundwork for our entire understanding of glucose and insulin regulation. We now know that these islets are precisely where the magic happens for controlling your blood sugar.
Right.
They house specialized cells that secrete both insulin and glucagon, two key hormones that are constantly adjusting their output. They act like a finely tuned thermostat, releasing more or less hormone in direct response to your blood glucose levels, diligently maintaining that delicate balance.
Wow. Okay, but the definitive connection between the pancreas and diabetes, that wasn't fully cemented until a truly pivotal moment in 1889.
Right, that came a bit later.
That's when two researchers, Minkowski and von Mering, conducted a landmark, albeit accidental, study involving dogs. They were actually studying fat absorption. And as part of their experiment, they surgically removed the pancreas entirely, a total pancreatectomy. But what they unexpectedly observed was revolutionary. These dogs suddenly developed glucosuria, meaning glucose appeared in their urine, a clear sign the body couldn't manage sugar.
A huge clue.
This was accompanied by ketonuria, which are chemical byproducts produced when the body starts burning fat for fuel instead of sugar, along with coma and eventual death. This accidental but powerful finding directly linked to the pancreas to what we now recognize as diabetes.
And that accidental discovery was a massive scientific leap forward. It directly paved the way for the monumental identification of insulin itself, which occurred in 1922 by Frederick Banting and Charles Best.
Banting and Best, okay.
Their method was quite ingenious for the time. They worked with diabetic dogs whose pancreases had been allowed to atrophy, essentially shrinking. They then extracted and homogenized pancreatic tissue from these atrophied glands.
Right.
When they injected this pancreatic extract back into the diabetic animals, remarkably, it temporarily reversed the diabetic condition. This elegant experiment provided undeniable proof of the existence of a vital hormone, insulin, and quite literally ushered in a new era for diabetes treatment.
Life-changing.
Absolutely transformative, life-saving moment in medical history. #tag the embryological journey of the endocrine pancreas.
So if this organ is so incredibly critical, you have to wonder, when does it actually begin to form in a human fetus? How early in development does this tiny yet mighty pancreas start its incredible journey?
That's an excellent question, and it truly speaks to the fundamental importance of this gland. Pancreatic formation begins surprisingly early, during the 5th week of gestation.
5th week, wow.
It starts not as one, but as two separate structures: the dorsal and ventral endodermal pancreatic buds. These buds emerge at a crucial anatomical crossroads, right at the junction of the foregut and the midgut, essentially, where the early digestive tube begins to differentiate.
Okay.
Both of these buds are initially comprised of endoderm, which is the innermost germ layer of the embryo, and they are then covered by splanchnic mesoderm, which provides structural support.
Fascinating. So these tiny buds are where it all starts. How do all those specialized cells we just talked about, like the hormone-producing ones and the digestive ones, differentiate from these initial embryonic structures?
The differentiation process is a marvel of developmental biology. Both the acinar cells, which perform the digestive exocrine functions, and the islet cells, the endocrine workhorses, differentiate directly from those endodermal cells within the embryonic buds.
Makes sense.
The surrounding splanchnic mesoderm, on the other hand, eventually develops into the dorsal and ventral mesentery, providing the crucial connective tissue and structural support. What's truly remarkable is how early specific cell types begin to make their appearance.
Like when?
The first glucagon-producing cells, known as A cells, are actually observable in embryos as young as 3 weeks old.
3 weeks.
Yeah, and by approximately 10 weeks of gestation, you start to see the initial rudimentary organized islets of Langerhans beginning to form.
And what about the crucial insulin-producing B cells? When do they make their grand entrance onto this developmental stage?
The B cells, absolutely central to glucose regulation, primarily undergo their formation and significant proliferation before birth.
Okay, before birth.
There's an especially significant burst of their growth that continues strongly up to the first 2 years of a child's life. This early and rapid growth is clearly reflected in a doubling of the B to A cell ratio neonatally, right after birth.
Double.
This highlights the increased growth and functional importance of B cells from the very beginning, setting the foundational stage for the lifelong function of glucose homeostasis. It's really a testament to the body's foresight, preparing for independent metabolic control.
When we think about the adult pancreas, it's easy to overlook its incredible microscopic architecture. We know it's made of endocrine cells, organized into the islets, and digestive acinar cells. But zoom in, and you realize just how tiny these islets are, and how many are packed in there, given they make up such a small percentage of the total mass.
It's truly astounding when you zoom in on that microscopic level. In an adult pancreas, the endocrine cells, the islets of Langerhans, comprise less than 2% of the overall pancreatic mass.
No, less than 2%.
Yet, despite this seemingly small volume, your adult pancreas contains approximately 1 million individual islets. Each one is a miniature, highly efficient factory containing around 3,000 cells.
3,000 cells per islet.
And their individual diameters can range from a mere 40 micrometers, that's smaller than the width of a human hair, up to a full millimeter, which is still quite small. This intricate and complex architecture is what allows for their highly specialized and vital functions.
So we've got these tiny, powerful factories, each containing thousands of cells. What are the main cell types within an islet, and what specific hormones are they pumping out? Let's break down each one. What's an A cell do?
Absolutely. Let's look at this complex choreography. Our sources, particularly Table 39.1, lay it out nicely. First, the A alpha cells. These make up about 10% of the islet mass and are typically located in the periphery or outer edge of the islet.
On the edge. Huh?
Their primary job is to secrete glucagon, which, as we'll discuss, acts as insulin's counterregulator, raising blood sugar. They also produce minor products like glycine, TRH, CCK, endorphin, PP, and pancreastatin, though their main clinical significance comes from glucagon. Next, and arguably the most critical players, are the B beta cells. These are the dominant population, making up to 70% of the islet mass, and they are centrally located within the islet, almost like the command center.
70%. Central command.
They are responsible for secreting insulin, the master anabolic hormone that lowers blood sugar. Their minor products include TRH, CGRP, amylin, pancreastatin, and prolactin. Their critical central position within the islet strongly hints at their paramount importance in regulating the other cells through direct communication.
And what about the others that round out this cellular team? The D, D2, and F cells.
Rounding out the main cast, the D cells constitute about 5% of the islet mass and are relatively evenly distributed. Their main hormone is somatostatin, often appropriately called the universal inhibitor due to its broad suppressive effect.
The inhibitor. Got it.
Then we have the D2 cells, also around 5% of islet mass and evenly distributed, but they specifically secrete vasoactive intestinal peptide, or VIP. Finally, the F cells make up approximately 15% of the islet cell mass. These are located in the periphery, similar to A cells, and they secrete pancreatic polypeptide, or PP. It's also worth a quick mention that the pancreas, especially in abnormal states, can harbor even rarer cell types. For example, EC cells are less than 1% and secrete substance P and serotonin, though these aren't typically associated with a distinct tumor syndrome.
Okay.
And while G cells, which secrete gastrin and ACTH-related peptides, are not found in the normal adult pancreas, they can be present in tumor scenarios like gastrinomas, producing an excess of these hormones.
That's a lot of specialized cells in such a small space.
Yeah.
Does their location within the entire pancreas, not just within the individual islet, also matter?
Yes, it adds another fascinating layer of anatomical complexity and functional distribution. While A cells are quite evenly distributed throughout the entire gland, B and D cells are particularly concentrated in the body and tail of the pancreas.
Okay, body and tail for B and D.
Conversely, F cells are found in a higher concentration in the uncinate process, that hook-shaped part of the pancreas that wraps around the duodenum. S cells are pretty evenly spread out.
Got it.
This regional distribution can have important implications, especially when clinicians are considering the most likely location for certain types of pancreatic neuroendocrine tumors.
Here's where it gets really interesting and incredibly efficient. How do these cells, packed together in these tiny islets, actually communicate and coordinate their hormonal symphony? There must be some incredible internal communication system at play, like a tiny internal messaging network.
You've hit on a crucial point that's key to their efficiency. The islet's internal communication, which is brilliantly facilitated by its rich portal microcirculation.
Portal microcirculation.
Think of it like a tiny, self-contained factory floor with a very specific internal plumbing system. Afferent arterioles, tiny arteries, enter the islet at its periphery. From there, blood flows inward to the central B cells.
Inward first.
Then outward to the A cells, which form a mantle around the core, and finally to the more distal peripheral D cells. This specific directional flow pattern allows for a very precise and rapid, intricate feedback loop.
How so?
For example, the B cells are strategically positioned to release insulin that directly bathes the A cells, inhibiting their glucagon secretion.
Direct inhibition.
And the A cells, in turn, stimulate D cell secretion. This direct internal signaling within the islet ensures incredibly rapid and coordinated hormonal responses to blood glucose fluctuations, preventing metabolic chaos.
And it's not just communication within the islet, is it? The pancreas also has its major exocrine, or digestive role. How does this endocrine function we're talking about connect the digestive part of the gland? Is there an islet-acinar axis?
Absolutely. There's a vital and often overlooked islet-acinar axis that beautifully links the endocrine and exocrine functions. Even though the islets constitute less than 2% of the total pancreatic volume, the arterial blood supply to the pancreas predominant flows first to the islets.
First to the islets.
Only after passing through the islets does this blood, now rich with islet hormones, then perfuse or flow into the exocrine portion of the gland.
Okay, so the digestive cells get hormone-rich blood.
Exactly. This means the exocrine cells, which produce digestive enzymes, are bathed in blood already laden with islet hormones. Physiologically, this allows the insulin from B cells to directly stimulate pancreatic exocrine secretion, amino acid transport into the cells, and the synthesis of digestive proteins and enzymes.
So insulin helps digestion.
It does. And conversely, glucagon from the A cells acts in a counter-regulatory fashion, inhibiting these very processes. It's a wonderfully integrated system where the hormonal output of the islets directly influences the digestive work of the rest of the pancreas, ensuring efficient nutrient processing.
So let's zoom out to the bigger picture. We've touched on it, but the primary overriding function of the endocrine pancreas is the incredibly tight regulation of glucose homeostasis through the precise actions of insulin and glucagon. How do these two primary regulators perform their roles in this delicate balancing act?
It's truly a classic metabolic duet, a perfectly choreographed dance between two opposing hormones. Insulin and glucagon maintain glucose homeostasis through a reciprocal relationship and sophisticated feedback mechanisms that are constantly responding to even small fluctuations in your blood glucose.
Push and pull.
Exactly. When your glucose levels rise, say, after a meal, insulin is secreted to lower them by moving sugar into cells. When glucose levels drop, like during fasting or exercise, glucagon is released to bring them back up by releasing stored sugar.
Right.
They work in opposition, but in such perfect synchronicity to keep blood sugar within a very narrow, healthy range, preventing both dangerously high and dangerously low levels.
Let's delve into insulin, often called the anabolic maestro or the body's master builder. What exactly are its main functions once it's released into the bloodstream?
Insulin is indeed a powerful anabolic hormone, meaning it promotes the building up of complex molecules and energy storage throughout your body. Its primary action is to promote glucose transport into most cells. Think of insulin as the key that unlocks the cellular doors, allowing glucose to enter from the bloodstream.
Not all cells.
There are a few key exceptions. B cells themselves, which make insulin, hepatocytes in the liver, and central nervous system cells, they have different mechanisms for glucose uptake.
Okay.
Beyond glucose uptake, insulin also actively inhibits glycogenolysis.
Breakdown of stored sugar.
Right, and it inhibits fatty acid breakdown, preventing the release of energy from fat stores. Concurrently, it stimulates protein synthesis. All of these actions are geared towards energy storage, making glucose available to cells for immediate use while building up reserves for later.
That sounds incredibly complex for a single hormone. How is this incredible hormone actually made and released by the B cells? Let's walk through the synthesis and release process from within that tiny islet.
It's a remarkable cellular process. Insulin starts its life in the B cells as a larger inactive precursor called proinsulin.
Proinsulin, okay.
This proinsulin is synthesized in the endoplasmic reticulum. You can think of it as the cell's protein factory, and then it's transported to the Golgi complex, where it's further processed and packaged. There, it undergoes a crucial cleavage event, breaking down into the mature insulin molecule and a residual C-peptide. The insulin molecule itself consists of two polypeptide chains, an A chain and a B chain, cleverly joined together by two disulfide bridges.
And the C-peptide.
What's important to note for diagnostic purposes is that insulin and C-peptide are secreted into the bloodstream in exactly equimolar amounts, meaning for every single molecule of active insulin, precisely one molecule of C-peptide is also released. They're always a pair.
Always together. Got it.
After this cleavage, the insulin is moved via tiny cellular roadways called microtubules into secretory granules, where it's stored, ready for rapid release into the bloodstream through a process called exocytosis when the B cell is stimulated, typically by rising glucose.
So the B cells are ready to go at a moment's notice. How sensitive are they to changes in glucose? And what does that immediate and sustained response look like when your blood sugar starts to rise?
The B cell sensitivity to glucose changes is truly impressive, almost like an incredibly precise sensor. It can detect even small fluctuations and is maximally stimulated at glucose concentrations ranging from 400 to 500 milligrams per deciliter.
That's quite high.
It is. That's the max stimulation point. When glucose levels rise, the islets react immediately with a short burst of pre-stored insulin ready to go in those granules. This initial burst lasts for about 4 to 6 minutes.
Like burst.
This is then followed by a more sustained secretion of insulin, which requires the B cell to actively synthesize new hormone molecules to keep up with the demand. It's a finely tuned biphasic response, a quick first wave, then a steady, sustained flow.
And once insulin is released, how does it actually get glucose into the cells that need it for energy? What's the role of the insulin receptor or those glucose transporters we hear about?
Once released into the bloodstream, insulin circulates until it finds and binds to a specific 300 kilodalton glycoprotein cell surface receptor on target cells. Think of this binding as insulin acting like a very particular key fitting into a very specific lock on the cell's surface.
Key in a lock.
The degree of stimulation of this receptor is directly dependent on the concentration of insulin available. After this binding, glucose is actively transported across cell membranes throughout the body. This transport is facilitated by various membrane-bound glucose transporters, often referred to as GLUTs, each with varying affinities for glucose, allowing different cells to take up glucose efficiently when needed.
This sounds like a perfectly designed system, but we know it can go wrong, leading to widespread health issues. Where does insulin resistance, which is so critical in conditions like type 2 diabetes, fit into this picture?
This raises an important point, and it's precisely where we see a major disruption. Insulin resistance, the hallmark of type 2 diabetes, occurs when the body's cells that are supposed to respond to insulin either have a decreased number of these specific insulin receptors on their surface or a decreased affinity of those receptors for insulin.
So the lock of the key isn't working right.
Exactly. It means that even with sufficient or even high amounts of insulin being produced by the pancreas, the cells aren't responding effectively. The key isn't unlocking the door as it should. This leads to elevated blood glucose levels despite the pancreas working hard. Understanding this fundamental breakdown is absolutely critical for comprehending the basis of such a widespread health issue like type 2 diabetes.
Okay, and now let's turn to glucagon. What's its role in this glucose balancing act, especially in counteracting insulin's effects?
Glucagon, a 29 amino acid polypeptide, is secreted by the A cells. Its primary function is quite literally the opposite of insulin. It elevates blood glucose levels.
Raises blood sugar.
It achieves this by stimulating two key processes, primarily in the hepatocytes, or liver cells: glycogenolysis, which is the breakdown of stored glycogen into glucose, and gluconeogenesis, the synthesis of new glucose from non-carbohydrate sources like amino acids or lactate.
So it makes new sugar and releases stored sugar.
Correct. The islet A and B cells, as we mentioned, respond reciprocally to serum glucose concentration. So as insulin secretion goes up, glucagon typically goes down, and vice versa. This constant push-pull ensures stable blood sugar.
I've heard glucagon referred to as a stress hormone. Can you explain that connection? Is it like a burst of energy when you're under pressure?
Yes, that's an important aspect of its function. Along with hormones like epinephrine, adrenaline, cortisol, and growth hormone, glucagon is indeed considered a stress hormone. This is because it plays a crucial role in increasing the availability of metabolic fuel, specifically glucose, during times of physical or emotional stress, ensuring your body has readily available energy for a fight or flight response.
Makes sense.
Interestingly, glucose itself has a strong suppressive effect on glucagon secretion, creating another elegant feedback loop to prevent excessive glucose production when it's not needed.
And what happens if glucagon secretion becomes dysfunctional? What are the clinical consequences of too much or too little of this critical hormone?
Just like with insulin, dysfunctional secretion of glucagon can have significant consequences. For example, excess glucagon can lead to hyperglycemia, contributing to chronically high blood sugar, which is often seen in diabetes.
Too much leads to high sugar.
Right. Conversely, insufficient glucagon can lead to profound and dangerous hypoglycemia, causing dangerously low blood sugar levels, especially during fasting or intense exercise.
Too little leads to low sugar.
Exactly. It's also hypothesized that dysfunctional glucagon secretion may play a significant role in the persistent elevation of blood glucose levels observed in diabetes, indicating that managing diabetes isn't just about insulin, it's about the insulin-glucagon balance.
But it's not just insulin and glucagon, right?
Yeah.
It seems like there are clearly other players in this incredibly complex system that influence glucose homeostasis.
Yeah.
What other hormones are involved, starting with signals from the gut?
You're absolutely right. It's a symphony with many instruments. Enteric peptide hormones released from the proximal gastrointestinal tract significantly influence glucose homeostasis through what's known as the enteroinsular axis.
Enteroinsular axis, gut to pancreas.
Precisely. This axis explains a fascinating phenomenon. Orally administered glucose has a demonstrably greater effect on insulin secretion than an equivalent amount of glucose administered intravenously, even if the blood glucose levels achieved are similar.
Really? Eating sugar boosts insulin more than we eat sugar.
Yes. The gut is clearly sending powerful signals to the pancreas to prepare for incoming nutrients.
So these gut signals that boost insulin are called incretins. I've heard that term.
Precisely. The key incretins are glucose-dependent insulinotropic polypeptide, or GIP, and glucagon-like peptide-1, GLP-1. These intestinal hormones are released in response to the ingestion of nutrients, particularly carbohydrates.
What do GIP and GLP-1 do?
They have a number of important biological effects. They directly stimulate insulin release from the B cells in a glucose-dependent manner. They inhibit the secretion of glucagon and somatostatin. And they are even thought to contribute to the maintenance of beta cell mass, which is crucial for long-term pancreatic health.
Wow, quite versatile.
They also delay gastric emptying, meaning food stays in your stomach longer. And they can even inhibit feeding, collectively working to optimize glucose uptake and utilization after a meal. And just as there are stimulators, your body also has humoral inhibitors of insulin secretion. These include somatostatin, amylin, leptin, and pancreastatin, all working to fine-tune and, at times, suppress the insulin response, ensuring it's not overactive.
Speaking of other hormones, ghrelin is often dubbed the hunger hormone. How does it connect to glucose regulation beyond just making you feel hungry?
Ghrelin, a 28 amino acid peptide hormone discovered in 1999, is produced by ghrelin cells primarily in the GI tract, especially the stomach. It exerts a series of metabolic effects directly impacting glucose metabolism.
Like what?
Ghrelin primarily inhibits insulin release, increases hepatic glucose production in the liver, and prevents glucose disposal in muscle and adipose tissues. Collectively, these actions lead to hyperglycemia, or high blood sugar, and impaired glucose tolerance.
So it raises blood sugar.
It does. This hormone also plays a fascinating, almost paradoxical role in different metabolic states. In diet-induced obesity, ghrelin can exacerbate hyperglycemia, while in situations of starvation or severe calorie restriction, ghrelin actually increases blood glucose concentrations to help maintain glucose homeostasis. It's a powerful, ancient survival mechanism.
And what about leptin, the hormone that signals energy stores from fat cells? How does it fit into this intricate dance?
Leptin is a peptide hormone produced in adipose, or fat cells. It's released into the circulatory system in proportion to your body's energy stores, acting as a crucial feedback mechanism.
Telling the brain about fat stores.
Right. It signals to regulatory centers in your brain to inhibit food intake and regulate body weight. In response to adequate fat stores, leptin primarily inhibits insulin secretion, providing a negative feedback loop to the pancreas.
Okay.
This raises an interesting point in obesity. In obese individuals, leptin levels are typically increased due to higher fat mass, which might exacerbate hyperglycemia. However, it's also believed that in obesity, there's often a state of leptin resistance, meaning the brain doesn't fully respond to its signals, leading to a continued lack of inhibition of food intake, despite the body having ample energy stores.
Beyond hormones, what about the brain's direct influence? Is there a direct neuronal control mechanism connecting the brain and the pancreas for insulin and glucagon, almost like a central nervous system override?
Sure. Absolutely. It's a very sophisticated level of control. Both insulin and glucagon secretions are under significant neuronal control. It's a complex interplay of nerve signals from your autonomic nervous system.
How does that work for insulin?
For instance, vagal, or cholinergic, activity, which is part of your rest and digest system, directly stimulates the release of insulin. Insulin release is also stimulated by the release of specific peptides from autonomic nerves, such as GRP, CCK, gastrin, and enkephalin in VIP, as well as by beta sympathetic nerve stimulation, part of your fight or flight system.
And inhibition.
Conversely, insulin release can be inhibited by substances like neurotensin, substance P, somatostatin, and alpha sympathetic nerve stimulation.
What about glucagon?
For glucagon, its secretion is primarily stimulated by sympathetic neural transmitters like norepinephrine, epinephrine, adrenaline, and certain amino acids like arginine and alanine, which signal low glucose or stress. So your nervous system is constantly fine-tuning these critical hormonal responses, often without you even realizing it.
You mentioned somatostatin as one of the inhibitors in that complex mix. It's often called the universal inhibitor. Can you tell us more about this hormone and its broader role?
Somatostatin is a small 14 amino acid polypeptide secreted primarily by the islet D cells. When administered exogenously, meaning from an outside source, it absolutely lives up to its name. It has a remarkably broad inhibitory effect.
What does it inhibit?
It significantly suppresses the release of insulin, glucagon, and pancreatic polypeptide, PP, from the pancreas. Beyond that, it also broadly suppresses gastric, pancreatic, and biliary secretion throughout the digestive system.
But does it do that normally inside the body?
That's the nuance. It's important to note that the direct influence of endogenous somatostatin, the stuff your own body naturally produces within the islet on the secretion of other islet hormones, hasn't been definitively proven to be as widespread as its exogenous effects might suggest. This raises questions about its local paracrine effects versus systemic endocrine effects.
So, if its endogenous effects are still being fully understood, what about synthetic versions? Have we developed analogs that mimic its powerful inhibitory actions?
Yes, quite successfully, and these have been a significant therapeutic advancement. Both long-acting and short-acting synthetic octopeptides have been developed that are designed to mimic the pharmacological actions of natural somatostatin.
How are they better?
These synthetic peptides are engineered to have a much longer half-life in the serum compared to the natural endogenous somatostatin, and they are even more potent inhibitors of key hormones like growth hormone, glucagon, and insulin secretion.
And what are the clinical applications for these powerful synthetic analogs? Where are they used in medicine today?
The potent inhibitory effect of these synthetic somatostatin analogs has led to significant and diverse clinical applications. They are primarily used to treat a range of exocrine and endocrine disorders of the pancreas and GI tracts. This includes managing conditions like severe secretory diarrhea, helping to close bowel and pancreatic fistulas where digestive fluids leak, and treating various endocrine hypersecretory syndromes where the body is producing too much of a particular hormone, like in certain neuroendocrine tumors. They effectively dampen excessive hormonal and secretory activity, providing crucial symptom relief and disease control.
Now let's talk about pancreatic polypeptide, or PP. What's its story, given its enigmatic nature?
Pancreatic polypeptide, a 36 amino acid polypeptide, is secreted by the islet F cells. It belongs to the peptide U-neuropeptide Y family, which are generally involved in appetite regulation and gut motility.
Does it affect appetite?
Interestingly, yes. Infusions of PP in humans have been observed to cause a loss of appetite and reduced food intake, suggesting a potential role in satiety, making you feel full.
So it has some effect, but its true physiological role seems a bit mysterious, almost like a supporting actor rather than a main character.
That's precisely it. It's true, precise physiological role in day-to-day metabolic regulation remains largely unclear. Consequently, its primary clinical usefulness is mostly limited to its role as a diagnostic marker for other endocrine tumors of the pancreas. It's more of an indicator than a direct therapeutic target for most conditions.
How is its secretion regulated, and do its levels change in disease states, making it a useful marker?
PP secretion is predominantly regulated by cholinergic innervation, meaning nerve signals from the parasympathetic nervous system, specifically the vagus nerve.
Vagus nerve control.
Right. In fact, if a patient undergoes a surgical vagotomy, which severs the vagus nerve, it completely eliminates the increased PP response normally observed after meals, highlighting this strong neural connection.
And in disease.
In terms of disease, PP secretion is known to be increased in diabetes and with normal aging, leading to higher circulating PP levels. Conversely, the absence of PP may play a role in the type of diabetes observed after a total pancreatectomy or in cases of chronic atrophic pancreatitis where the pancreas is severely damaged.
It seems like the islets are a veritable factory of chemical messengers, constantly producing a complex array of peptides. What other fascinating hormones are at play here, beyond the main ones we've discussed?
Indeed, the cast of peptide hormones secreted by islet cells is quite diverse, even beyond the primary ones. These include VIP, vasoactive intestinal peptide, amylin, galanin, and serotonin, to name a few.
Tell me about VIP.
VIP, a 28 amino acid polypeptide, stimulates insulin release and inhibits gastric secretion at physiological levels. It's found widely throughout the GI tract, but also notably in the respiratory tract, where it causes vasodilation and bronchodilation.
And amylin.
Then there's amylin, a 36 amino acid polypeptide, also secreted by the B cells, often alongside insulin. Amylin actually inhibits both the secretion and uptake of insulin. Interestingly, deposits of amylin in the pancreas of patients with type 2 diabetes have been implicated in the pathogenesis or development of the disease itself, contributing to beta cell dysfunction.
Wow, so it might hurt B cells in type 2.
Potentially, yes. Pancreastatin is another peptide. It's part of chromogranin A, and it inhibits insulin secretion. While gastrin-producing cells are present in the fetal pancreas, they are notably not found in the normal adult pancreas, only appearing in certain tumor conditions.
Any others?
And the list doesn't stop there. Many additional peptides have been reported in normal islets, and notably are often overexpressed in islet cell tumors. These include TRH, glycentin, CCK, peptide YY, GRF, CGRP, prolactin, ACTH, parathyroid, hormone-related protein, and even ghrelin. It truly underscores the incredible biochemical complexity and the potential for a wide array of hormonal dysfunctions within this small but mighty organ when things go awry.
Let's shift gears now to a very significant, albeit rarer, area of study. Pancreatic neuroendocrine tumors, or PNETs. These account for less than 3% of all pancreatic neoplasms, pancreatic cancers, which might sound insignificant. But their incidence, how often they occur, is actually quite alarming.
What's truly fascinating here, and critical for understanding PNETs today, is the dramatic increase we've seen in their incidence. It has risen more than sevenfold in just 2 decades.
Sevenfold.
Yeah. Robust data from the SEER database showed the overall incidence of gastroenteropancreatic neuroendocrine tumors, including PNETs, went from about 1 case per 100,000 between 1973 and 1977, soaring to 3.65 cases per 100,000 between 2003 and 2007. PNETs specifically made up about 7% of these cases, showing a distinct upward trend.
That's a huge jump. Is there a clear reason for this increase? Is it that more people are getting them, or are we just getting better at finding them?
It's likely multifactorial, but it's primarily that we're getting much better at detecting them.
Better detection.
This observed increase is probably due to a combination of factors. Increased awareness among physicians, leading to more vigilant detection, the more frequent use of advanced imaging like CT and MRI in routine screenings, and significant improvements in the sensitivity of diagnostic testing. All these factors contribute to finding more tumors that might have previously gone undetected.
Okay. How are PNETs broadly classified?
PNETs are broadly classified into 2 crucial categories: functional and non-functional. Functional tumors are those that secrete hormones in excess, leading to characteristic clinical syndromes and physiological disruptions, often the first sign.
Like an insulinoma causing low sugar.
Exactly. It's worth noting that even if multiple hormones are found in a tumor, functional specifically means it causes clinical symptoms due to hormone secretion. Non-functional tumors, on the other hand, historically presented with local symptoms from tumor growth pain, mass effect, biliary obstruction.
But that's changing.
Right. A significant modern trend is that these non-functional tumors are increasingly being identified incidentally on imaging performed for entirely unrelated reasons, often before they cause any symptoms at all. This shift in detection is having a profound impact on how we think about and manage them.
So once a PNET is found, how do clinicians categorize these tumors, especially when considering their potential for malignancy and the best treatment approach? It seems like it's not as straightforward as other cancers.
That's a crucial insight because, unlike most other solid tumors where malignancy is determined by the primary tumor's histopathology, in PNETs, malignancy can only be definitively determined by the actual presence of metastasis.
Only by spread.
This is a fundamental distinction. The most widely used system for classifying and staging is the World Health Organization's WHO 2010 system. It classifies based on differentiation, how much they resemble normal cells, and grade, reflecting proliferative activity, how fast they grow.
Grades G1, G2, G3.
Exactly. Grade is categorized as low grade, G1, intermediate grade, G2, or high grade, G3. This grading is based on microscopic factors: appearance, mitotic rates, how fast cells divide, organ invasion, angioinvasion into blood vessels, and the Chi-67 proliferative index, which measures the percentage of cell actively dividing.
So I'm understanding correctly, G1 and G2 are generally considered well differentiated, while G3 is poorly differentiated. What does that tell us about their behavior?
Precisely. G1 and G2 are well differentiated, looking more like normal cells, growing relatively slowly. G3 tumors are poorly differentiated, look very abnormal, and are much more aggressive. The G3 designation is by far the most important prognostic indicator, signaling a significantly worse outlook.
Yeah.
High-grade, poorly differentiated PNETs are sometimes called neuroendocrine carcinoma, making up less than 3% of PNETs. But it's critical to emphasize, even well-differentiated G1 or G2 tumors still possess malignant potential and can metastasize. The differences in behavior persist even in patients with metastatic disease.
Are there other staging schemes clinicians use besides the WHO system?
Yes, there are, which can add complexity. The AJCC and PNETs have staging schemes, often similar to those for exocrine pancreatic cancers, focusing more on tumor size and spread, not explicitly including grade in the primary criteria. There was also a proposed TGM system. More recently, the 8th edition AJCC staging system has shown good prognostic discrimination, which is helpful. #hashtag the genetic landscape of PNETs.
Here's where it gets really interesting. What drives these tumors at a genetic level? Are they always sporadic, just popping up, or can genetics play a role, perhaps running in families?
That's a crucial question. While most PNETs are sporadic, arising without a clear inherited cause, a significant number are indeed associated with specific genetic syndromes.
Like which ones?
The most common is multiple endocrine neoplasia type 1, or MN1. This syndrome has a classic triad: PNETs, parathyroid adenomous hyperplasia, and pituitary adenomas.
And what's the underlying genetic cause of MN1? What gene is responsible?
MNN1 is caused by mutations or deletions in a tumor suppressor gene called menin on chromosome 11q13. It's inherited in an autosomal dominant fashion. Only one mutated copy is needed.
What does menin normally do?
The menin protein is part of the histone methyltransferase complex involved in controlling the cell cycle, specifically the G1 to S phase progression, basically, controlling cell division. When this suppressor function is lost, it predisposes individuals to neoplastic growth in endocrine tissues like the parathyroid, pituitary, and pancreas.
Okay. Any other syndromes?
Another important one is von Hippel-Lindau, or VHL syndrome. Inherited mutations in the VHL gene cause risks for renal cell carcinoma, pheochromocytoma, benign CNS tumors, and crucially for us, pancreatic lesions like NETs, microcystic adenomas, and cysts.
So managing PNETs in VHL patients must be quite a challenge, given the other associated tumors. Does that influence how aggressive we are with the pancreatic lesions?
It definitely is complex. Like MN1 VHL-associated PNETs are often multifocal within the pancreas and associated with tumors elsewhere. Interestingly, VHL-linked PNETs generally behave more indolently or slowly. It's even suggested they can often be safely observed until 2-3 centimeters.
And not always.
Not always. Specific germline mutations in exon 3 of the VHL gene may be associated with a more aggressive phenotype, warranting earlier treatment and closer surveillance. Precise genetic testing helps refine risk and tailor treatment.
So for the majority of PNETs that aren't tied to these specific inherited genetic syndromes, what's going on genetically? Is there an accumulation of genetic events?
Yes, for most sporadic PNETs, it's an accumulation of genetic events driving tumorigenesis. Sequencing has revealed common mutations. For instance, inactivating mutations in MN1 are seen in about 44% of sporadic tumors, even without the full syndrome.
Wow, even in sporadic cases.
And mutations in DAX and ATRX are found in 25% and 18% respectively. These genes' protein products are involved in p53-mediated DNA damage repair, a critical pathway for preventing uncontrolled growth. What's particularly insightful is that patients with mutations in MN1 or xanthine-CTRX have actually shown prolonged survival.
Longer survival, that's counterintuitive.
It suggests these specific alterations might lead to less aggressive behavior. Another very important finding is the dysregulation, specifically upregulation of the mTOR pathway in a large proportion of these tumors. mTOR is key in regulating cell growth and proliferation.
That sounds like it has direct clinical implications for treatment, potentially paving the way for targeted therapies.
It absolutely does. This understanding translates directly into patient benefit. The mTOR pathway upregulation led to targeted therapies. The mTOR inhibitor everolimus is now FDA approved for advanced NETs. Potentially, mutational testing could one day guide personalized treatment.
That's huge.
What's truly remarkable is how genetically distinct PNETs are from pancreatic adenocarcinoma, the more common and aggressive type. No KRS mutations in PNETs, unlike adenocarcinoma. TP53 mutations are rare in well-differentiated PNETs, common in adenocarcinoma. This underscores their different behaviors and responses to treatment.
So are there also genetic differences between well-differentiated PNETs and the more aggressive, poorly differentiated PNETs?
Yes, there are, explaining their varied behaviors. In well-differentiated tumors, MN1 and DAX-ATRX expression is often abnormal. In poorly differentiated tumors, DAX-ATRX is typically normal. Instead, these aggressive ones show high incidence of abnormal p53, retinoblastoma expression, and overexpression of the anti-apoptotic protein BCL2.
So BCL2 could be a target.
It could be, specifically in these more aggressive, poorly differentiated PNETs, opening avenues for future drug development. These genetic insights constantly refine our understanding.
Imagine you're a patient. What's the journey like to get a diagnosis for a PNET? The symptoms can vary so incredibly widely, from nothing at all to severe pain, making it a real diagnostic puzzle.
The presentation varies enormously, making diagnosis a challenge. Some are completely asymptomatic and incidental finding. Others might have classic functional hormonal syndromes like hypoglycaemia from an insulinoma or severe ulcers from a gastrinoma.
Right.
And then there are those with nonspecific abdominal symptoms from tumor growth. Pain, jaundice, anorexia, weight loss. Non-functional tumors especially often have vague symptoms until they cause mass effect, compressing organs, so they're frequently diagnosed at a more advanced stage.
So what's the general evaluation process?
Regardless of presentation, there's a systematic algorithm. All suspected PNET patients need, at minimum, first, a careful history for functional tumor symptoms, with biochemical confirmation if needed. Second, cross-sectional or advanced imaging to pinpoint location. Third, evaluation for metastatic disease. And fourth, a thorough family history for genetic syndromes like MEN1 or VHL. This comprehensive approach is essential.
So when a patient actually has symptoms that suggest a functional tumor, what specific screening tests are done to confirm that hormonal overproduction?
If a patient has a hyper-enhancing pancreatic mass on imaging suggesting PNET, and they have symptoms, the history screens for specific signs, neuroglycopenic symptoms, confusion, tremors from low sugar, chronic diarrhea, severe ulcer history, characteristic skin rashes.
Matching symptoms to hormones.
Exactly. These guide which specific hormone or peptide levels to test. Family history is also crucial for MEN1. Importantly, a full, broad hormonal screen is not necessary in asymptomatic patients without suggestive symptoms. That's usually overkill.
Are there any general biomarkers that can aid in diagnosis and surveillance even if they don't point to a specific hormone syndrome?
Yes, a very useful general biomarker. PNETs often produce distinct GI peptides that may not cause symptoms but are useful for diagnosis and surveillance. The most prominent is chromogranin A, CGA.
Chromogranin A. Right.
CGA levels correlate with tumor presence in both functional and non-functional PNETs. It's valuable for confirming diagnosis and for post-treatment surveillance to monitor for recurrence or progression.
But I imagine there are some caveats with chromogranin A, right? It's not a perfect test on its own.
Absolutely right. While useful, CGA levels can be elevated by other non-tumor factors. Caution is needed.
Like what?
They can be elevated in patients taking proton pump inhibitors, PPIs, for acid reflux, those with atrophic gastritis, and patients with hepatic or renal insufficiency. So it must always be interpreted within the full clinical context.
Once we suspect a PNET, how do we find it? What are the key localization techniques to pinpoint the tumor's exact location?
Pinpointing the tumor is critical. The vast majority of non-insulinoma or non-gastrinoma PNETs are identified on initial CT or MRI. Because of their rich vascular supply, PNETs are typically hyper-attenuating. On contrast-enhanced CT, they light up brightly.
Like a spotlight.
Exactly. This characteristic vascular blush, especially in the arterial phase, is critical. MRI shows them as low-signal T1, high-signal T2. Sensitivity depends on size and location. For very small duodenal gastrinomas, using water instead of oral contrast on CT helps.
So if CT or MRI don't quite get us there, what's the next step in the localization puzzle?
If initial imaging doesn't definitively localize it, the next step is typically endoscopic ultrasound, or EUS. EUS has about 90% overall sensitivity, and it's actually better than CT or MRI for tumors smaller than 3 centimeters.
But up for small ones.
Yes. Especially effective for insulinomas, often small and hard to see otherwise. Limited for small duodenal tumors, though, maybe 50% sensitivity there. A big advantage is EUS allows fine needle aspiration, FNA, for pathological diagnosis, especially useful for non-functional tumors.
That's incredibly helpful for small tumors. But what if the tumor still isn't clear? Or if we need to see if it's spread, especially if it's a type that has specific receptors?
In those situations, somatostatin receptor scintigraphy, or SRS, becomes very useful. Most PNETs, except insulinomas, have abundant somatostatin receptors.
So SRS works for most, but not insulinomas.
Correct. This allows SRS to be very effective, over 80% sensitivity for non-insulinoma PNETs. For gastrinomas, where over 90% express receptors, sensitivity is 80-100%. Very useful for detecting liver metastases, too.
What are the limitations of SRS? It sounds so precise, but I'm guessing there's a catch.
While sensitive, it has limitations. It can show tracer uptake in normal sites or benign conditions, leading to potential false positives. More importantly, it lacks precise anatomical localization. It might only show the general vicinity, not the exact spot, a drawback for surgical planning.
So how do we overcome that anatomical precision issue, getting a clearer picture for surgery?
That's where hybrid SPECT CT comes in. This combines single photon emission computed tomography, SPECT-PUNAR, with traditional CT overcoming SRS limitations. SPECT-TCT provides precise anatomical localization, crucial for discriminating tumor from physiological uptake.
Much clearer picture.
Much clearer. Studies show impressive sensitivity, 96%, and specificity, 97%, for G1, G2 PNETs. It really enhances pinpointing accuracy.
And if all else fails, are there any other techniques, perhaps more invasive ones, that doctors use to find these elusive tumors?
Yes, a few more invasive options. If all previous studies fail, angiography can be useful. For insulinomas, it detects about 70% larger than 5 millimeters, showing a characteristic vascular blush.
Okay.
If standard techniques still fall short, portal venous sampling for insulin or gastrin levels can be employed. It doesn't pinpoint the exact spot, but localizes to a region, head, body, tail, invaluable for operative planning.
So it narrows it down.
Exactly. Building on that, arterial stimulation venous sampling is even more advanced, though rarely needed now. Calcium, for insulinomas, or secretin, for gastrinomas, is injected into arteries with simultaneous venous sampling, over 90% sensitivity. But modern non-invasive techniques usually suffice.
Once these PNETs are localized and it's confirmed they haven't spread beyond the pancreas, what's the gold standard for treatment? Is surgery always the primary approach, and what does that involve?
For non-metastatic, symptomatic, or functional PNETs localized preoperatively, surgical resection is indeed the primary treatment, offering the best chance for cure.
Surgery is key.
The specific approach and extent are dictated by tumor type, location, stage, grade, and patient factors. Usually it's a partial pancreatectomy head, distal, or even enucleation, just scooping out the tumor. Can be open or minimally invasive.
What are the main goals of this surgery, beyond just removing the tumor?
The goal is to completely remove the primary tumor and, importantly, any regional lymph nodes potentially involved. Crucial for cure and accurate staging.
Are there any specific challenges or risks associated with pancreatic surgery for PNETs that patients should be aware of?
Yes. One significant challenge is the often soft texture of the surrounding normal pancreas. This increases the risk of a pancreatic fistula after partial pancreatectomy, where digestive fluids leak. While often less problematic than leaks after a Whipple for other cancers, they're still common after distal pancreatectomy and enucleation and need careful management.
And what about enucleation specifically? Is there any controversy around that approach, given it's a more limited resection?
There is some ongoing discussion. While enucleation preserves more healthy pancreas, reducing diabetes risk, a theoretical disadvantage is no regional lymph node sampling.
Right, less staging info.
Knowing node status gives prognostic info, but there isn't clear evidence of therapeutic value to routinely removing nodes in all enucleation cases. Similarly, the need for splenectomy with distal pancreatectomy is debated regarding lymph node yield versus preserving the spleen. Ongoing discussions aim to optimize outcomes.
This is a huge debate in the medical community right now, isn't it? Especially there's so many more incidental findings of PNETs thanks to advanced imaging. What's the historical perspective versus how we approach it now?
You're absolutely right. Critical and evolving debate. Historically, any PNET, even small and asymptomatic, was thought malignant, so resection was recommended. Better safe than sorry.
Made sense then.
But the surge in identifying incidental asymptomatic PNETs via imaging raised questions of overdiagnosis and overtreatment. Autopsy series show PNET prevalence from 1% to 10%, much higher than clinical prevalence. Suggests many never become clinically relevant.
So maybe we don't need to operate on all of them.
Exactly. Given the high morbidity of pancreatic resection, there's significant debate and many recent studies evaluating observation for small, non-functional PNETs.
So what do the current guidelines and evidence suggest regarding observation versus immediate resection for these small, asymptomatic tumors? What's the professional consensus?
Guidelines have evolved. The ENETS 2016 guidelines state observation of tumors 2 centimeters is safe, provided they are WHO G1 or low G2, Chi 67-10%, and no malignant findings on imaging.
Less than 2 centimeters, low grade, no bad signs.
Yeah.
Observation, okay.
Right. Likewise, the most recent NCCN guidelines also offer observation for non-functional PNETs 2 centimeters, a shift towards personalized, less invasive management for the low-risk tumors.
And if observation is chosen, what do the surveillance protocols look like? It can't just be a passive wait-and-see approach, right?
Exactly. Not passive, proactive, meticulous surveillance. If observing, ENETS recommends mandatory EUS and MRI scans every 6 months initially. If stable, lengthen to 12 months. But if it grows 0.5 centimeters or more, reevaluate for surgery. NCCN recommendations are similar. Structured monitoring is key.
What kind of data from actual patient outcomes supports this observational approach? It must be compelling to shift clinical practice.
Several observational studies provide compelling data. One review found incidentally discovered tumors had 86% 5-year progression-free survival versus 59% for symptomatic. Suggests incidental ones might be less aggressive.
Interesting. Another study looked at 131 small, asymptomatic, non-functional PNETs. Among the 77 observed, median size, 1 centimeter, didn't change over 45 months, and crucially, no disease progression or death. In contrast, 46% in the operative group had complications, mostly leaks, highlights surgical risks. So observation seems safe, surgery has risks. Further reinforcing this, a retrospective study compared 104 observed, 3 centimeters, to 77 resected patients. No observed patients developed metastases or showed size change. While some eventually had surgery, only a few due to growth, most by preference. Several other studies of 2-centimeter tumors show similar findings. While some research suggests resection for 1.5 centimeters improves survival, the benefit for smaller lesions remains unclear. So what's the overall conclusion on this nuanced debate, especially for clinicians deciding on the best path for their patients?
The collective data strongly supports observation for incidental tumors smaller than 2 centimeters, particularly low-grade ones. However, the critical caveat for an elite understanding: when conservative management is chosen, meticulous and careful surveillance per established guidelines is paramount, allows monitoring and prompt intervention if needed. A personalized, dynamic strategy, not one size fits all. Hashtag tag non-metastatic pancreatic neuroendocrine tumors unlocalized preoperatively.
Now, what if a PNET is strongly suspected, maybe due to symptoms and high hormone levels, but despite all those advanced imaging techniques, it simply cannot be localized before surgery? This must be incredibly rare and frustrating now.
You're right. With modern imaging, this scenario should be very rare for a functional tumor. However, in those rare cases, intraoperative ultrasonography becomes essential. Numerous reports attest to its high accuracy in this context, helping surgeons find the elusive tumor during the operation.
So ultrasound during surgery?
Yes. Requires full mobilization of the pancreas for access and visibility.
And what kind of tools are used for this intraoperative ultrasound? Is it different from a standard ultrasound?
Yes, specialized probes. High-resolution transducers, 7.5-10 millihertz, image the pancreas directly. For deeper penetration, like assessing the liver, a 5 millihertz transducer. Islet tumors usually appear sonlucent, darker, uniform consistency. Color Doppler helps detect adjacent vessels, and crucially, the pancreatic duct, lucent tube without flow. Identifying the duct is vital to prevent fistula after procedures like enucleation.
And if it's an unlocalized insulinoma, which we know can be very small and elusive, what's the specific approach then?
In that unlikely event, beyond intraoperative ultrasound and careful palpation, biopsies should be taken from the pancreatic tail to evaluate for nidicoblastosis, an overgrowth of insulin cells mimicking insulinoma.
Check for nidicoblastosis.
As for more extensive surgery, a distal pancreatectomy might be considered in desperation if no tumor is found, but it remains controversial due to morbidity and risk of missing the tumor anyway. Precise localization is always the goal.
What happens when these tumors have already spread, most commonly to the liver, at the time of diagnosis? Is the prognosis always grim, or is there a different outlook compared to other metastatic cancers?
Critical area and a point of differentiation. Metastases are detected at diagnosis in 40–80% of PNET patients, liver most frequent. While distant mets are a poor prognostic indicator, long-term outcomes for neuroendocrine liver mets are much more favorable than for pancreatic adenocarcinoma or other GI tumor mets.
More favorable? Why?
This inherent, indolent, slow-growing nature of PNETs, even when metastatic, means aggressive therapy is often warranted. Patients can live many years, even with advanced disease.
And this requires a very specialized, coordinated team, right? It sounds like no single doctor can manage this alone.
Absolutely. Treatment necessitates highly coordinated, multidisciplinary care. Surgeons, oncologists, interventional radiologists, all working together. Combined approaches are common. Aggressive surgery, ablative liver therapies, systemic chemo, or targeted therapy used simultaneously or sequentially to improve survival and quality of life.
So let's talk about liver surgery for metastatic disease. Can it actually be curative, or is it primarily palliative, aiming to relieve symptoms?
Liver resection can be curative or palliative, though potentially curative surgery is possible in only a smaller subset, maybe 10–25% of those with liver mets.
When is resection recommended?
General recommendation is if more than 90% of the disease can be removed. Some studies now suggest a 70% threshold can yield similar long-term outcomes. Surgery can be concurrent with primary tumor removal or staged if disease is extensive. Bilobar might need staging plus portal vein embolization to grow the remaining liver before a second surgery.
What factors indicate a better prognosis after liver surgery for PNETs? Are there specific criteria that guide these decisions?
Several factors associate with better prognosis. G1, G2 tumor grade, well differentiated, absence of distant lymph node mets, absence of extrahepatic or peritoneal mets. Even after curative resection, recurrence rates in the liver are high, around 80% at 5 years.
High recurrence.
But despite this, overall 5-year survival is still impressive, 85%. Much better than other liver mets, underscoring the value of aggressive surgery.
Are there studies comparing surgical resection to other therapies for liver metastases? It seems like surgery would be the most effective, but it's also very invasive.
While aggressive, surgery often yields best long-term results. No randomized trials comparing liver resection to other treatments, mostly observational studies. But these generally suggest better long-term survival after resection compared to other liver-directed therapies. One study reported 71% 5-year survival post-hepatectomy versus 31% for chemoembolization. Compelling evidence for surgery when feasible.
And what about debulking when the disease is widespread and unresectable? Is that still a controversial approach? Just removing some of the tumor but not all?
Debulking for unresectable disease remains debated. However, it's generally considered reasonable and beneficial for G1, G2 disease, primarily in the liver, in good surgical candidates. Consensus often suggests debulking if 90% removed. Recent studies suggest maybe 70% removed yields similar outcomes. Moreover, debulking can improve efficacy of subsequent locoregional treatments by reducing overall tumor burden. Hashtag liver-directed therapy for metastatic disease.
So if surgical resection of liver metastases isn't possible, what are the alternatives for liver-directed therapy, targeting the disease specifically in the liver?
Beyond resection, several other liver-directed therapies exist. Radiofrequency ablation, RFA, cryoablation, transarterial embolization, transarterial chemoembolization, TCE, and radioembolization. Important. These aren't generally curative alone and have morbidities, abscess, cholecystitis, liver failure, typically reserved for symptomatic unresectable disease or as a bridge.
Tell me about RFA.
Radiofrequency ablation is safe for unresectable mets 5 centimeters. Uses heat to destroy cells. Effective for controlling hormone symptoms from functional tumors.
And the transarterial therapies.
Given their multifocal, highly vascular nature, neuroendocrine liver mets suit transcatheter transarterial therapies. Deliver agents via hepatic artery. Transarterial embolization uses materials to block blood supply, starving the tumor. Transarterial chemoembolization, SAC, adds chemo, doxorubicin, melphalan, streptozocin, with embolizing agents, achieves 20x systemic chemo concentrations intratumorally, more localized, potent effect, fewer systemic side effects.
Now, what kind of results do these transarterial therapies achieve? Do they shrink tumors or just control symptoms?
High partial response rates, significant tumor reduction, and even higher symptomatic improvement, especially in functional tumors. While bland chemoembolization popular for years, newer approaches use drug-eluting beads and yttrium-90 Y90 microspheres for potentially more durable responses and targeted radiation. Selective intra-arterial radiotherapy Y90 microsphere showed 55% response rate, 88.9% disease control at 3 months. Powerful local control. Hashtag cytotoxic and targeted systemic therapy.
Beyond surgery and liver-directed therapies, what about medication to fight these tumors throughout the body? Has systemic therapy improved for PNETs?
Yes, very significant improvements, moving beyond traditional chemo. Somatostatin analogs, SSAs, like octreotide and lanreotide are highly effective, often first-line systemic treatment.
What do they do?
They control hormone secretion from functional tumors, improving symptoms, and play a crucial role in stabilizing tumor growth in metastatic PNETs, acting as anti-tumor agents. There are 5 SSTR subtypes, SSTR1 or 5. Different SSAs have varying affinities. Knowing receptor type can guide therapy.
Any proof they slow tumor growth?
Landmark studies prove their anti-tumor effect. The PROMID study showed octreotide LAR significantly increased time to progression in metastatic well-differentiated PNETs. Monthly injection, well-tolerated, though gallstones can occur. The CLARINET study evaluated lanreotide autogel versus placebo in G1 low G2 SSTR positive PNETs. Showed lanreotide significantly prolonged progression-free survival, regardless of liver tumor volume, solidified SSA role in controlling growth.
What about traditional cytotoxic chemotherapy? Is that still used? And for what types of PNETs?
Cytotoxic chemo is still crucial, particularly for poorly differentiated neuroendocrine carcinomas, more aggressive. Also used in unresectable low-grade PNETs, often combined. Agents like dacarbazine, doxorubicin, 5-FU used.
Response rates.
20-45% in G1, G2 PNETs with streptozotocin-based regimens. Temozolomide alone or with capecitabine, significant advance. Showed 70% partial response, 18 months PFS, 92% 2-year survival in G1, G2 PNETs. Impressive. For high-grade tumors, platinum-based regimens, cisplatin, etoposide preferred, 42-67% response.
And what about targeted therapy that focuses on specific molecular pathways? This sounds like the cutting edge.
It is indeed, based on deeper understanding of PNET pathogenesis, led to highly effective targeted therapies. One is everolimus, an oral mTOR inhibitor. mTOR pathway often upregulated in PNETs. Randomized trial, 11 months PFS versus 4.6 months placebo, FDA approved.
Another one.
Sunitinib, a tyrosine kinase inhibitor targeting multiple receptors. PDGFR, VGFR, 12, c-KIT, FLT3. PNETs often overexpress VEGF, VEGFR, crucial for blood vessel formation. Randomized trial, 11.1 months PFS versus 5.5 months placebo, also FDA approved.
So these targeted therapies have truly changed the game for advanced PNET treatment, shifting away from more toxic chemotherapy for many patients.
Absolutely. Targeted therapies, along with SSAs, have largely replaced cytotoxic chemo as first line for advanced, well-differentiated PNETs. More effective, often better tolerated options. Beyond these, peptide receptor radionuclide therapy, or PRRT, is promising and innovative, especially for tumors with strong SSTR uptake. Uses radio-labeled SSAs, Y90 Lu-177, to deliver targeted radiotherapy. Smart bomb for cancer cells.
To cure them.
Complete response rare, 0.6%, but results encouraging. Partial regression, 7.37%. Stabilization, 42.86%. Highly targeted approach with significant potential for long-term control. Still investigational in some regions. #tag liver transplantation for metastatic PNETs.
Can you actually get a new liver if the cancer is spread there? That sounds very aggressive, maybe controversial for PNETs, given organ scarcity.
Aggressive, yes, but critical to discuss. PNETs strongly favor liver mets, often confined there. Even after treatment, recurrence in remnant liver within 2 years is common. Highlights liver tendency and indolent nature. Because of this, total hepatectomy with liver transplantation proposed as potentially curative for unresectable neuroendocrine mets confined to the liver. It's the only metastatic indication for liver transplant by some criteria. Unique place in oncology.
Are there specific criteria for who can receive a liver transplant for PNET metastases? Can't be for just anyone.
Yes, very strict criteria, often Milan criteria for PNETs, typically. Age 55, well-differentiated tumor, Chi 67, 5%, primary tumor completely resected with portal drainage, 50% liver involvement, and crucially, absence of extrahepatic disease. Strict criteria aim to maximize success and rationalize organ allocation.
And what do the outcomes look like with these strict criteria? Long-term survival.
When criteria is strictly adhered to, impressive 5-year overall survival up to 90% reported in select cohorts. Remarkable for metastatic cancer. However, not all centers adhere strictly. Largest study, 213 transplants in Europe. 5-year OS, 52%. Found hepatomegaly, high-grade tumors, extrahepatic resection associated with worse outcomes. Emphasizes patient selection.
Given severe organ scarcity, is it still controversial?
Certainly. While survival rates can compare to hepatocellular carcinoma transplants, they may not be significantly greater than non-surgical therapies for neuroendocrine mets. Given organ scarcity, its role remains debated ethically and clinically regarding optimal allocation, especially when other effective, non-curative therapies exist.
Let's zoom in now on the most common functional PNET, the insulinoma, causing hypoglycemia. The hypoglycemia enigma.
Insulinoma is indeed most common, incidence 1 to 2 per million year. Clinical presentation classically defined by Whipple's triad 1935. 1. Neuroglycopenic symptoms consistent with hypoglycemia. 2. Documented low plasma glucose when symptoms present. 3. Complete relief of symptoms with glucose, still the gold standard.
What are the common symptoms patients experience? Sounds disruptive.
Very widely. Some get sympathetic nervous system overactivity symptoms, fatigue, weakness, fearfulness, intense hunger, tremor, diaphoresis, sweating, tachycardia, fast heart rate. Others get central nervous system disturbances as brain lacks fuel. Apathy, irritability, anxiety, confusion, excitement, disorientation, blurred vision, delirium, stupor, coma, seizures. Often symptoms present for years before diagnosis. Many report significant weight gain from compensatory eating.
What are the characteristics of insulinomas themselves? Size, location.
Fairly consistent characteristics. ABG, age 45, distributed equally throughout pancreas, despite B cells mostly in body tail. Rarely ectopic, duodenum, splenic hilum. Typically small, 1 to 1.5 centimeters, hard to localize. Crucially, surgical resection usually curative because 85–95% are benign and solitary. 5% associated with MEN1, more likely multiple malignant.
How do you definitively diagnose an insulinoma, differentiating from other causes? Needs precision.
Requires precise biochemical approach. First, detailed history. Symptom timing relative to meals, meds, family social history. When hypoglycemia is suspected, measure blood glucose precisely, not home meter. Gold standard often the 72-hour monitored fast. Patient supervised, blood samples taken to catch hypoglycemia. But if episodes observed and labs obtained then, full fast might not be needed. During documented hypoglycemia, key labs: plasma glucose, insulin, C-peptide, proinsulin, beta-hydroxybutyrate.
What do the labs show in insulinoma?
Elevated insulin, C-peptide, proinsulin. Crucially, beta-hydroxybutyrate, 2.7 millimole insulin's anti-ketogenic effect. Helps differentiate. Oral hypoglycemic agents detectable in plasma. Insulin autoimmune has antibodies. Surreptitious insulin. High insulin, low C-peptide, proinsulin. Exogenous insulin lacks C-peptide. High insulin to glucose ratio, 0.3 suggestive, as is C-peptide 1.2 ml with glucose 40 mg.
Biochemical markers are central.
Once diagnosed, how is it localized and treated? Surgery key, but unique considerations. General PNET principles apply, crucial exception. SRS is not indicated for insulinomas, rarely express SSTRs. Surgical resection is mainstay, only curative option. Because 90% benign, enucleation often preferred when feasible. Scoops out tumor, preserves pancreatic mass, reduces diabetes risk. But not if 2 millimeters from main duct or for large tumors, risk of fistula.
What if enucleation isn't suitable?
Formal anatomic resection needed. Distal pancreatectomy, central pancreatectomy, or pancreatic duodenectomy, Whipple, depending on location size. Preoperatively, critical to prevent severe hypoglycemic attacks. Glucose infusions, diazoxide, decreases B-cell insulin release, often used once diagnosis confirmed.
What happens if an insulinoma cannot be localized even with modern imaging before surgery? Is the surgeon just guessing?
Rare now. If so, blind exploration with intraoperative ultrasound, careful palpation exploration finds most. Requires full pancreas mobilization. If still unlocalized, biopsies of tail for nocidioblastosis. Distal pancreatectomy controversial in this setting.
And what's the prognosis for patients with insulinoma, typically cured?
Prognosis excellent after complete excision of benign insulinoma, normal life expectancy. Malignant need more extensive resections. Even with metastatic insulinoma, tumor debulking may result in biochemical cure. Residual disease may be inactive or slow growing. Persistent hyperinsulinism managed with SSAs. Hepatic artery embolization, diazoxide, chemo, streptozotocin plus 5-FU. Median survival 5 years even with metastatic disease, highlighting relative indolence.
Next, the gastrinoma, known for its fierce impact via Zollinger-Ellison syndrome, or ZES, causing massive acid production.
Gastrinoma is second most common functional PNET, 1 per 2.5 million year. First described 1955 by Zollinger and Ellison, mean edge 50, slightly more common in men, 60%. 75% sporadic, 25% MEN1. Important genetic link.
So what's the pathophysiology? Why such severe acid problems?
Unique pathophysiology. Gastrin, normally from stomach, stimulates acid. Tumor gastrin not subject to normal regulation, not suppressed by high pH, not appropriately stimulated by food, paradoxically stimulated by secretin. This unregulated hypergastrinemia leads to continuous excessive peptic acid hypersecretion, causing severe refractory peptic ulcer disease.
What are the main symptoms? What's particularly suspicious beyond typical heartburn?
Most common, fulminant peptic ulcer disease. Duodenal ulcers most frequent. Jejunal ulceration further down, highly suspicious. 75% have significant abdominal pain. Diarrhea common, almost 2/3. 10–20% diarrhea only symptom. Acid-induced diarrhea stops with NG aspiration, differentiates from other secretory diarrheas. GRD, increasingly common, 13 patients, due to acid volume.
Where are these gastrinomas typically found? The specific hot zone?
Yes, very specific. 90% in the gastrinoma triangle, bounded by cystic duct, duodenum 23 junction, pancreas neck body junction. 60% in duodenum itself, mostly first portion, can be in lymph nodes, primary or metastatic.
How do you definitively diagnose ZES, differentiating from other causes of high gastro?
Diagnosis depends on demonstrating both hypergastrinemia and increased gastric acid secretion. Normal fasting gastrin 100 pgml. 100–1000 can be other causes. 1,000 highly suggestive with increased gastric acid. Crucial to rule out pernicious anemia, high gastrin, no acid hypersecretion, and PPIs. Stopped 2 weeks prior.
Okay.
Definitive diagnosis. Elevated serum gastrin plus gastric aspirate pH2. pH3, no meds. Strongly suggests ZES not the cause.
And if there's still doubt, a specific provocative test.
Yes, if diagnosis uncertain, secretin stimulation test highly specific. Fasting gastrin taken, then secretin IV. Gastrin samples taken after. Rise 200 pgml above baseline, highly characteristic, 87% patients. Virtually no false positives. False negatives possible with H. pylori. Key for confirmation.
Once diagnosed, what's the treatment approach? Symptom control with meds or surgery too, despite small hidden locations?
Once diagnosed, primary immediate goal. Prevent acid secretion, relieve symptoms. 2 PIs are absolute mainstay. Often need much higher doses than for typical ulcers GRA. Titrate dose to keep basal acid output 10 ml QRA 5 if prior acid-reducing procedure. PPI is so effective, they've largely made total gastrectomy unnecessary for symptom management. Huge advance. For localization, CT-MRI, water contrast for duodenal, SRS indicated, almost all express SSTRs, EUS for small pancreatic lesions, angiography plus SEX stimulation if needed, operative exploration if strongly suspected but unlocalized.
And for operative treatment, these can be tough to find. How do surgeons approach it?
Operative treatment for curative resection or palliative cytoreduction. Presence, absence of malignancy, most important prognostic factor. Finding them is challenging. Surgeons miss 5-8% intrap, if not localized, pre-op. Thorough exploration, entire abdomen, liver, specific areas, small, large bowel. Crucial, careful inspection of gastrinoma triangle with interrupt ultrasound. For duodenal tumors, transillumination with endoscopy, duodenotomy incision with bimanual palpation detects many missed on imaging. Aggressive search needed. Reception type, segmental resection, distal pancreatectomy or pancreaticoduodenectomy. Whipple may increase disease-free survival in MEN1. Duodenal recurrence is common. Resection of gross lymphatic spread may increase DFS. Unfortunately, despite aggressive surgery, almost 50% recur symptomatically biochemically by 5 years. Persistent challenge.
What happens with metastatic gastrinoma, especially liver, unmanaged? Prognosis.
50% have metastatic disease at diagnosis, often liver. Primary focus remains acid control with PPIs. Total gastrectomy rarely needed now, maybe for gastric carcinoids from hypergastrinemia or PPI intolerance. Crucially, total gastrectomy cures acid symptoms but has no effect on disease progression or survival. SSAs decrease gastrin but rarely suppress acid effectively without PPIs.
So even with metastatic disease, still hope for long-term survival. Different from other cancers.
Yes, key distinction. Aggressive surgery indicated because patients live 20 years even with residual disease. Can follow aggressive or benign course. Aggressive form, 25%. Larger pancreatic tumors, liver mets, worse survival, 10-year OS 30% and 90% non-aggressive. Most significant predictor of survival. Presence of liver metastases. Lymph node mets, not predictive. Resection of all gross disease mets offers palliation, 50% long-term survival, but cures rare. Chronic disease for many.
This was defined by an incredibly dramatic symptom, relentless watery diarrhea. Tell us about VIPomas and the challenging syndrome they cause.
VIPomas are rare, 1 per 10 million year. Arise from pancreatic islet D2 cells. Release high VIP syndrome, also known as WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria, or pancreatic cholera due to diarrhea severity volume. Aggressive tumors, 23 malignant, 70% metastatic at presentation, location, 90% in pancreas, 75% body tail. Also colon, bronchus, liver, adrenal, sympathetic ganglia, 10%.
Typical age, demographic.
Most diagnosed middle age, 10% 10 years old in young, usually non-pancreatic tumors like ganglionomas. Typically solitary 3 centimeters at diagnosis, easily ID'd on imaging, 95% sporadic, 5% EN1.
What's the pathophysiology behind the profound diarrhea? How does VIP cause that much fluid loss?
Specific mechanism. VIP acts directly on intestinal epithelial cells as colon to activate adenylate cyclase. Increases cyclic AMP, stimulates massive hypersecretion of fluid electrolytes into lumen-perfuse, watery, isoosmotic secretory diarrhea. 3 to 5 L a day, unlikely if 700 ml a day. Persists despite fasting, secretory, and NG aspiration, differentiates from ZES.
What other conditions in the differential diagnosis for such severe diarrhea? Needs thoroughness.
Consider laxative abuse, bacterial parasitic diarrheas, carcinoid syndrome. Check urine 5-HIA. Diagnosis confirmed by measuring blood VIP levels. Normal 200 pgml, VIPoma 225, 2000 pgml. Measure after overnight fast.
Associated complications.
Yeah.
Sounds like significant issues beyond discomfort.
Complications severe due to massive fluid electrolyte loss. Significant weight loss, dehydration, crampy abdominal pain, electrolyte abnormalities profound, SPP, hypokalemia, 400 milliliter plus, day loss, cardiac rhythm disturbances, sudden death, metabolic acidosis, bicarbonate loss. 75% have hypochlorhydria, low no stomach acid, decreased magnesium, phosphorus, rapid meticulous correction critical before surgery.
How treated given complications and high malignancy rate?
Treatment starts with aggressive preoperative hydration, correction of electrolytes acid base, somatostatin analogs commonly used pre-op, highly effective reducing diarrhea volume, facilitating replacement, stabilizing patient. Glucocorticoids if diarrhea persists. Surgical management, formal anatomic resection, not enucleation, with negative margins, lymphadenectomy due to high malignancy. No evidence supporting debulking in metastatic setting.
Prognosis for VPOMAS.
5-year survival, 68% after resection. Presence of metastatic disease is a poor predictive factor.
This one often has a very distinct set of symptoms, a medical fingerprint. Let's talk about glucogenomas and their characteristic 4D syndrome.
Glucogenoma is rare, 1 per 20 million year, 2-3x more common in women, larger, EBG, 5-10 centimeters at diagnosis, almost always pancreas, 65-75% body tail, correlates with alpha cell distribution. Malignant, 50-80%, 80% of malignant have liver mets at diagnosis. Most sporadic, 5-17%, MEN1.
So the 4D syndrome, what are those distinct symptoms?
Classic clinical presentation, the 4Ds. 1, diabetes, 76-94%, usually mild. 2, dermatitis, characteristic necrolytic migratory erythema, 23 patients, often first symptom. Believed due to severe amino acid deficiency, parenteral amino acids can make lesions disappear. Trace element deficiency, malnutrition contribute. 3, deep vein thrombosis, common significant morbidity, mortality. 4, depression, also severe catabolic state, weight loss, fat protein depletion, vitamin deficiency.
Doesn't diagnose. Blood test.
Yes, diagnosis by measuring fasting glucagon levels, normal 100 pgml, 1000 pgml diagnostic. Given size malignancy, usually easily localized with standard imaging once suspected.
Treatment approach, especially with severe systemic symptoms.
Treatment begins with urgent medical therapy to improve nutritional status, reverse catabolic effects, supplemental enteral nutrition, octreotide to reverse catabolism, IV amino acids for dermatitis, critically prophylaxis against thromboembolism instituted early, surgical, complete anatomic resection for resectable disease.
Prognosis for glucogenoma.
5-year survival, 85%, no METs, 60% with metastatic disease. Highlights impact of METs.
Even rarer, but with its own unique fingerprint, the somatostatinoma. What defines this elusive tumor?
Somatostatinoma is exceedingly rare, 100 cases reported. First described 1977. Because they secrete excess somatostatin, universal inhibitor, cause unique symptom constellation, though often nonspecific. Full syndrome. Steatorrhea, fatty stools, diabetes mellitus, hypochlorhydria, low stomach acid, gallstones. Caused by inhibition of pancreatic enzyme hormone secretion, reduced gallbladder emptying.
Given nonspecific symptoms, how diagnosed? Sounds challenging.
Right, nonspecific symptoms, rarely diagnosed pre-op. Suspect in patient with diabetes, gallstones, steatorrhea, SBT with pancreatic duodenal mass, fasting plasma somatostatin level 160 pgml suggestive, often confirmed by pathology.
Typical characteristics: size, location, malignancy.
Usually solitary, 85% 2 centimeters, 60% in pancreas, usually head, rest in duodenum, small intestine. Patients typically 50s, 60s. Tragically, high malignancy, 90%. Liver lymph node METs common at diagnosis, rarely MNN1, but associated with von Recklinghausen's disease and pheochromocytomas.
Prognosis, given rarity and high malignancy.
Data limited. Reports indicate 5-year survival, 30-60% for those with metastatic disease after resection. Highlights challenging nature, need for aggressive multidisciplinary treatment. #tag other rare functional pancreatic endocrine tumors.
And then a few others, even more incredibly rare, medical curiosities, but fascinating.
Indeed. Case reports document tumors secreting various other hormones, GRF, growth hormone releasing factor. GRFoma is almost invariably MNN1 associated, only 30% from pancreas. ACTH, cause Cushing syndrome, often with other endocrine syndromes, most common ZES, usually malignant. Neurotensin. Neurotensinomas cause hypokalemia, weight loss, hypotension, cyanosis, flushing, diabetes. Malignant. PP, pancreatic polypeptide. PPOMAs have high circulating PP, but no specific clinical syndrome, unless MEN1 associated, large and solitary. Elevated PP often seen in other endocrine tumor syndromes, important classification note. PP, neurotensin, calcitonin secreting tumors, sometimes classified as non-functional. Hormone products have little biologic consequence, rarely cause symptoms. Tumor relevant due to mass effect metastasis, not hormonal activity. Functional, critical symptoms from hormone. #tag genetic syndromes and pancreatic complications.
Let's revisit MNN1 with its strong PNET link. How do PNETs manifest in this broader genetic syndrome?
PNETs, very significant in MN1, occur 30–80%. Most common cause of tumor-related death in MN1 patients. Present younger, more likely malignant, characteristically multicentric disease, multiple tumors, complicates management, 50% metastatic at presentation.
Most common functional syndromes in MNN1 patients with PNETs.
Gastrinoma most common, 54%, often severe ZES. Then insulinoma, 21%, glucagonoma, 3%, vibipoma, 1%. Interestingly, non-functional PPON is very common, 80%. Useful marker, even if asymptomatic.
Management approach for MNN1 patients with PNETs, given multi-organ involvement. Can't just focus on pancreas.
Exactly. Complex multisystem disease. Requires coordinated, comprehensive strategy, staged treatment of all associated tumors, parathyroid, pituitary, adrenal, etc. Holistic approach vital.
Screening to detect all these potential tumors.
Comprehensive biochemical screening. Fasting gastrin, insulin proinsulin, PP, glucagon, chromogranin A, useful general marker. Screen calcium level if high, check PTH. If hyperparathyroidism, sestimate the parathyroid scintigraphy to ID adenoma hyperplasia.
Priority if hyperparathyroidism also present. Parathyroid or PNET first.
Crucial point. Hyperparathyroidism treated first. Correcting hypercalcemia improves PNET treatment outcome, safer and more effective. Prioritization, vital.
Gastrinoma is common in MN1. Unique characteristics for MN1-associated ZES versus sporadic.
Yes. Consider MN1 in ZES patients, 20% have MN1. Onset earlier, 5–10 years. MN1 gastrinoma is more often duodenal, multiple, 85% have lymph node mets. Interestingly, unlike sporadic 3-centimeter tumors, MN1 gastrinomas tend not to metastasize to liver. Key prognostic difference.
Surveillance for MNN1 patients after initial treatment, given multicentric risk.
Careful ongoing surveillance essential for life. Risk of new tumors recurrence. Annual EGD. Focus on eye removing larger duodenal lesions. Surgical resection for lesions appearing malignant. Rapid growth. New appearance. Proactive approach manages multiple potential sites. Aims for early detection.
We talked insulinoma causing hypoglycemia, but another condition looks similar, needs a different approach. What is non-insulinoma pancreatogenous hypoglycemia syndrome, or NIPHS?
NIPHS, or nocidioblastosis in adults, crucial differential for hyperinsulinemic hypoglycemia. High insulin, no obvious tumor. Pathologically, excessive B cell function, islet hyperplasia, more B cells. Dysplasia, abnormal cells. Histologically, B cells budding from near ducts lose normal islet structure, usually disease of infancy, rare in adults. Diagnostic challenge.
Very similar to insulinoma. How differentiated? Why distinction critical for treatment?
Differentiation critical, surgical treatment differs significantly. Wrong approach has serious consequences. Hallmark of NIPHS, postprandial hypoglycemia, within 4 hours after meal, often 1 to 2 agers. Contrast sharply with insulinoma, typically fasting hypoglycemia. However, NIPHS may also have positive 72-hour fast hypoglycemia with high insulin, C-peptide, proinsulin. Timing of symptoms is key clinical differentiator.
How ultimately diagnosed? Treatment, given it's not a discrete tumor.
NIPHS, primarily clinical diagnosis of exclusion. Rule out insulinoma first. Final diagnosis confirmed by pathology of resected pancreas and clinical response. Treatment, pancreatectomy, most common 95% distal. Dietary control, small, frequent, low-carb meals. Medical therapy, diazoxide, SSAs, to manage hyperinsulinism.
Sometimes cure for one problem leads to another, especially with pancreatic surgery. Endocrine complications, particularly diabetes.
Important point, highlights pancreas's delicate balance. Surgery, while necessary, can lead to endocrine insufficiency. One recognized complication, espray after bariatric surgery like Roux-en-Y gastric bypass, RYGB, is post-gastric bypass NIPHS.
Symptoms with post-gastric bypass, NIPHS, theorized cause. Sounds confusing.
Patients get postprandial neuroglycopenic symptoms. Low brain glucose after meals. Can be severe. Confusion, disorientation, unconsciousness, syncope, shakiness, tremors, abnormal behavior, anxiety, weakness, blurred vision, seizures. Uncommon but growing relevance with more RYGB. Hypoglycemic events may be underestimated. Theorized etiology complex. Obesity-induced B-cell hypertrophy not reversed. Inappropriate growth factor release. Persistent altered gut hormonal signaling, all leading to exaggerated insulin response post-meal.
How treated, since related to prior surgery?
First line. Rigorous dietary modifications, small, frequent, low-carb meals to dampen insulin spike. Medications, continuous glucose monitoring, acarbose, slows carb digestion, calcium channel blockade, diazoxide, SSAs often help. Surgical intervention, RYGB reversal or distal pancreatectomy only for refractory cases. Weigh risks versus benefits. Weight regain, comorbidities, pancreatic resection, most common, extent controversial, symptoms often recur.
What about diabetes after pancreatectomy for other conditions like cancer or chronic pancreatitis? Inevitable.
Diabetes, significant endocrine complication. Clinically apparent type 1 diabetes develops after destruction removal of 85% islet mass. 20-50% develop diabetes after resection, depends on extent, underlying health. Often preceded by some endocrine insufficiency. Pre-op HbA1c might predict. Chronic pancreatitis patients, diabetes very common post-op due to prior damage. Pancreatic cancer surgery, data polarized. Some report high diabetes incidence, others report glucose control improvements, relief of ductal obstruction tumor factors.
What about total pancreatectomy? Impact on blood sugar management.
Total pancreatectomy unquestionably leads to brittle diabetes. Notoriously difficult to control due to complete absence of endogenous glucagon to balance exogenous insulin. No natural backup against lows. However, longer-acting insulins, advanced monitoring have significantly improved management. Remains lifelong challenge.
Finally, how surgery is even used to treat diabetes itself. Leveraging the pancreas's own cells. Sounds like a true frontier.
Fascinating, rapidly advancing area. Surgery and cell biology intersecting. Autologous islet cell transplantation, significant role, particularly for severe chronic pancreatitis. Resection, partial total, improves quality of life, eliminates pain, improves appetite, reduces hospitalizations. Many chronic pancreatitis patients develop diabetes anyway.
So autologous transplant treats pancreatitis and mitigates diabetes. Powerful combo.
Precisely. Total partial pancreatectomy plus islet autotransplant offered at specialized centers. Treats pancreatitis definitively, mitigates diabetes, retains endogenous insulin glucagon secretion, C-peptide production, makes resulting diabetes far easier to control, less brittle, still have some internal regulation.
How does islet isolation and transplantation actually work? Sounds intricate.
Ingenious, labor-intensive, needs specialized facilities. Patient has pancreatectomy, tissue immediately to islet isolation facility. Meticulously digested with collagenase proteases, releasing islets. Islets purified. Return to same patient autologous via infusion into portal vein at time of surgery or later. Engraft in liver produce insulin C-peptide, function evaluated via glucose levels.
Results, success factors, permanent cure.
Results vary. 1,500 patients since 2000. Insulin dependence initially 40-80%, but notable decline over time, 10% independent at 10 years. Most remain C-peptide positive, diabetes more manageable. Improves pain symptoms of chronic pancreatitis, success factors. Hashtag islets isolated transplanted, cause of disease, best results. Non-diabetic pre-transplant, no prior pancreatic ops, younger patients, pre-adolescents. Rare complication. Portal vein thrombosis, 1%.
Beyond autologous, what about whole pancreas or allogeneic islet transplant for type 1, getting cells from a donor?
Another cutting-edge area. For select type 1 patients with difficult-to-manage disease, unresponsive, severe hypos complications, whole pancreas transplantation remains gold standard. 40,000 worldwide since 1966. Established rule.
Results benefits of whole pancreas transplant. Truly normalizes blood sugar.
Profound results. Immediate normal fasting postprandial glucose, normal HbA1c, effectively cures diabetes. Graft survival improved. 85% simultaneous pancreas kidney, 78% pancreas after kidney, 76% pancreas only at 1 year U.S. Better quality of life despite immunosuppression, stabilization improvements in retinopathy, nephropathy, neuropathy, macrovascular diseases.
How does allogeneic islet transplantation, donor islets, compare? As effective?
Less invasive than whole pancreas, but less effective for long-term insulin independence.
Right.
Current data. Long-term normoglycemia elusive. Even with multiple infusions, few stay normal long-term. CITR data. 70% insulin independent at 1 year. Including multiple infusions. 35% by 3 years.
If long-term independence challenging, benefits of allogeneic islet transplant, why do it?
Even partial function confers significant benefits. Dramatically decreased severe hypos, abated hypoglycemic unawareness, critical safety, persistent C-peptide, improved glycemic control, stabilized complications. Main challenge. Often needs 2 donors per recipient. Organ scarcity issue. Looking ahead, stem cell therapy, huge potential. Developing unlimited source of insulin-producing cells. Revolutionize treatment, bypass donor scarcity. Studies show successful in vitro differentiation expansion of embryonic cells, mouse human, from pancreatic ducts expressing insulin responding to glucose. Could provide an exhaustible supply. Game changer for millions. Hashtag tag outro.
Wow, what an incredible deep dive into the endocrine pancreas. From its tiny, intricate islets to its monumental impact on widespread conditions like diabetes and incredibly rare, complex tumors, it's abundantly clear this small organ plays an outsized role in our overall health and metabolic stability.
Indeed. We've journeyed through its remarkable history, its incredible cellular complexity, understanding the delicate reciprocal balance of hormones like insulin and glucagon, and delved into the sophisticated ways we diagnose and treat PNETs, as well as the significant endocrine complications of diabetes and the innovative surgical strategies addressing them.
Yeah.
What's truly remarkable is the precision with which the body attempts to maintain glucose homeostasis and the continuous innovation in both surgical and medical therapies when that delicate balance is lost, really pushing the boundaries of medicine.
It really makes you think about how interconnected everything is in the body, doesn't it? You've heard about the critical functions of each cell type, the intricate feedback loops that keep us going, and how even slight genetic shifts can lead to incredibly complex diseases. So what does this all mean for you, our listener? Perhaps it's an invitation to pause and consider the silent, tireless work happening inside you right now to keep you well. And what new questions does this deep dive spark for your own further exploration of the wonders of the human body and its intricate metabolic symphony?